All right, we've been sent a case today for evaluation. This case comes from a brand new owner who recently attended the Sirona training. And one of the things there's questions on this case is, can you help me walking through making a surgical guide using my Galileos? I have already extracted 3, 4, 11, 15, crowned 5 and 13, and I would like to place or plan on placing implants in sites number 3, 4, 11, 12, and 14, and maybe on 15 depending on how things heal. I have never made a surgical guide before and would like to use one in this case. Please advise. Thank you. So, um, so there's several things here. The first thing I would look at is, and then my first question always is, can I do the case? And then my part of that is, what kind of guide? And the great news here is we have all these fresh natural teeth right here that we can use to make an Opti guide. To make an Opti guide, we will need a full arch CEREC scan or a full arch impression/stone model for CCAT to convert into a CEREC scan. So in this particular case, we have not been sent any CEREC data, so I can't comment on the accuracy of that. But I do want to point out a couple of things that in this particular case and all cases that we can talk with our team members about. It looks like this patient is simply not biting on the bite stick. And the reason I know that is I can look here and see that tooth number 2 and 31 are occluding. And also I can see that the anterior teeth are in occlusion as well. Now, for ideal diagnosis, whether for a surgical guide or not, we do want to have separation of teeth. Just like with a Panorex, nothing would change here. We do want to have separation of teeth so that we can separate and see. One, diagnostically, things are better that way. And then from a surgical guide perspective, we definitely need that separation of the teeth to be able to demarcate the teeth and get accurate tooth registration. My next comment on this case is what I would need to properly evaluate this case is a scan about 4 to 6 months after the teeth have been taken out. Retrospectively, this may have been a great case to do immediate placement. It's difficult to tell what the case will look like afterwards, but the case was sent to me with some implants planned, as you can see here. So what I would like to do is go through and just base everything as if this were the case. So again, step 1 to order a surgical guide. 1, this is a great case for an Opti guide. No problem there. Step 2, let me back up on that. This is a good case for an Opti guide. Opti guide will work. We have a distal extension here. The only concern I have is we have the good news is we've crowned number 13, so we will have some type of tooth support on the patient's left-hand side. If this were a case where we had this long of a distal extension, I would probably then choose to go to a classic guide to get tissue support. Although they can do that in the Opti guide, but still the classic guide has a little bit better fit onto the teeth. So step 1, we would need CEREC data or a stone model that can be converted into CEREC data. Step 2, we would need a new scan and a new plan. Once we have all of this data and the implant plan correct, we'll go to the surgery tab. We'll click the order surgical guide button, and in this case we would select one of these 3 buttons and send this case over to CCAT and just follow through on the wizard. So let's go ahead and take a look. Here is the site for number 3. Based on what I see here right now, my first assessment is the implant needs to go a little bit deeper. This is with the tooth there, so the bone level is technically right here prior to extraction. So right here is what I would call bone level. I think all of this is tooth. Okay. I think that's the furcation right there. So I think all of the white is tooth, all of the red is the bone level, and based on that we can see our implant is way high there. So I would go ahead and drop this implant to about right here. As you can see, this gets into the sinus. That can, in this particular case, the sinus can be very easily managed by doing an up fracture. Just like so, adding some bone and grafting that area with the up fracture. An alternative would be to shorten the implant. Even shortening it to 10 still requires an up fracture. The next step would be to go to an 8. This is the least dense bone, the least quality of bone we have. 5 by 8 is an option. 5.7 by 8 is not bad. 5.7 by 10 would be better in this particular case. The other thing that I notice in this particular plan is we just may want to tilt this just a little bit to get our occlusal plane a little bit better, just like so. But in looking at this, we can see that we're in the arch form. You know, if anything, I may bring this a little bit to the lingual, just like so. And that may be a little bit better of a plan there for tooth number 3. We can see that we do have enough space between the adjacent root. That root goes right here. So I think we're okay there. Now if we move on to number 4, again, on this particular case, I would define bone level as right here. So probably along that line right there. I think the rest of this right here is all tooth. So in this particular case, I would probably take this implant to about right here. And again, we're going to be into the sinus. Again, we can shorten it to a 10. You know, that works. The other thing we have to look at is we need to have certain distance from the adjacent tooth. Sorry, from the adjacent implant. So we can see from view, customize, implant. Our drawings at 1.5. So ideally we want to have 1.5 to 2 millimeters. So we should be more than adequate right there. Again, depending on how the crown was designed on number 5, that may affect this. Now if we come over here to the axial view of this particular implant, we can see that we are quite a bit out to the buccal here. Looking at it, see where we have number 3, number 4 is way out to the buccal there. So in this particular case, I would need to bring this implant in like so. And this is where CEREC data really comes in handy, being able to better see exactly where your tooth is going to go, and being able to better see where your final restoration is going to go so that you can plan your implant to support that. So that would probably be my plan right there. Now we're going to go ahead and skip over to number 11. And again, I would say that our bone level is probably about right here on this particular case. So our implant is placed pretty well in this particular joint. I would still go ahead and make it a little bit subcrestal. Again, this will change now that the tooth has been removed already. Certainly there will be some changes here. And if we come to our axial view, we can see that we're just a little bit buccal based on what I would like, but not bad at all here. I think that's going to be fine. And then we go to an implant on site number 12. My first inclination here is that we are quite too close to this adjacent tooth. If also looking at the axial view, we can see we're on the buccal side of things. The other thing that I also notice here is that This is what the bone looks like. So we have quite a bit of the implant outside of the bone there. This would definitely be a case that would require some grafting, whether that's pre-implant grafting or grafting done at the time of placement. That will be up to the treating doctor there. And then we need to make sure that we have the 2 millimeters of spacing there. And then bring this back into the arch form like so, as much as possible. So definitely would like to do some grafting on this particular one. If we also take a look here, our occlusal plane is quite a bit off. So ideally this implant would probably be along this angle right here. This will give us, we could probably go something like that. This will give us a better occlusal force. Again, where that crown on 13 is potential an issue. We also have to take a look here at the proximity of the implant, and then even the angulation of this particular tooth implant placement as well. Again, without the prosthetic data, it becomes a little harder to distinguish and figure out exactly the angulation that we're at. And there. Now, as we go back to the posterior, here, what I'm seeing, what I'm seeing is bone right here and up to there. I'm also noticing quite a bit of something going on in the sinus. So this would be a case where we would definitely need some type of sinus augmentation. This would be a great case for some level of lateral sinus lift. Yeah, no question that this is a lateral sinus lift. We would want to get this cleared out, what's going on in the sinus. And based on what I'm seeing, what's going on in the sinus is being caused by tooth number 15, which has been removed. So we can see here this infection going on tooth 15 right in here. That's associated with all of this. So once we get that out, that should help quite a bit. But same thing here. Once this is cleaned out, this will also need a significant sinus lift as well. So the posterior left-hand side, to get any posterior teeth in 14 or 15 in that site, in those areas, this case will definitely need some significant augmentation. We can also see that we are quite a bit lingual on this plan here. So this plan probably needs to go something like that, somewhere in that ballpark. So a couple of things to kind of review. There's a lot going on in this case. With the data that's presented, I could definitely say that the right side is a possibility. The posterior left side is going to be quite a bit more involved. But if we can take a new scan after 4 to 6 months after the extractions with some CEREC data, that would be tremendously helpful to help get a final plan in this case. Thank you very much.